Hello and welcome, Dr. Pfeifer, Dr. Samantha Pfeifer from Weill Cornell. Thank you so much for speaking with me again today. We're going to be speaking a little bit about the latest ASRM update. So welcome.
Thank you very much for having me. I'm talking to you from my office in the city in my COVID scrubs.
Mm-hmm. How is the situation in New York? Is it getting any better?
It is getting a little better. There's fewer people being admitted to the hospital. There's still some very sick people, but there's fewer people being admitted than are discharged. So we have successfully flattened the curve, and things are going in the right direction. I think that the message is we achieved this success by social distancing and being very compliant with all those restrictions. So the concern is if we lessen these restrictions, what's going to happen? But for now, things are getting better.
Great, that's really good to hear. I've been speaking today about the latest HFEA announcements around the UK in terms of clinics submitting their cases for reopening on the 11th of May. So it would be great to know what the latest is with the ASRM, and if you wouldn't mind just letting people know how you're affiliated with the ASRM, that would be wonderful.
I'd be happy to. So I am a associate professor of clinical reproductive medicine at Weill Cornell Medical College in New York City, but I'm also on the board of directors of the American Society for Reproductive Medicine, and I am one of the members of the task force that crafted the ASRM recommendations regarding COVID-19. We first came out with our initial recommendations on March 17th. And I think, in thinking back, it was only about 6 weeks ago, and yet it seems like an eternity. We've been all sequestered. But, at the time we made those recommendations, the WHO had just declared that COVID-19 is a global pandemic. We had on Friday the 13th, New York City basically shut down, and Broadway, the lights went out on Broadway, even the theaters were closed, which was sort of a dramatic thing for a New York City person. And at the same time, we were seeing stories about hospitals in Italy that were totally overwhelmed and doctors having to make the decision of which patient goes on a ventilator and which patient goes without. Mm-hmm. So, there's certainly a lot of concerns about how bad the pandemic could be in the States and in New York City. So the COVID task force was convened in middle of March to look at what we can do to help. And the goals of the recommendations were really to explore how practices could practice at the same time optimizing the health of their patients and staff and protecting the health of their patients and staff, but at the same time acknowledging our social responsibility to adhere to the recommendations put forth for public health concerns and to reduce the spread of this terrible virus, which is very virulent and has no cure or treatment to date. So that was the setting of the initial recommendations. So the initial recommendations really came out in mid-March, and we recommended that no new treatments be started at that time, and that consideration be given to freezing embryos rather than transfer, just because we didn't know how prevalent the disease was going to be, and we just still don't know the impact of the virus on developing pregnancy. But at the same time, we felt it was important to continue cycles that had been initiated, and to support the care of our patients through minimizing face-to-face visits, but optimizing telehealth. And these recommendations are really there to respond to the acute phase of the pandemic. Since then, we've had two other updates to the recommendations which have come out, and in those updates, we have acknowledged that infertility is a disease, and as providers, we're committed to get patients back to receiving their treatment as soon as we can. But acknowledging that we really need to respond as a responsibility to our own patients, but also to the responsibility of our everyone, because how a disease affects everyone in the community can affect our individual patients. So how to keep reconcile both of those factors. So as this whole situation is evolving very rapidly, and I think back to it, I'm not so sure that we would have predicted that in the last week in April, we would be considering that the crisis is sort of somewhat quelled somewhat so that we could consider restarting treatment. I think that sort of has been for some a welcome surprise. I mean, some were envisioning 6 months where we couldn't take care of patients. So I think that this is, I know it's been very tough for everybody, for many, many patients, and for providers as well. But I think that, this was in a way a little sooner than we were anticipating. So it's actually good. But we've recently come out with the third update of our recommendations addressing reentry, if you will, how to reinitiate treatment with the goals of keeping our patients safe, reducing the spread of COVID, and yet allowing people to pursue treatment for the disease of infertility.
And what are those recommendations?
Well, the recommendations are really sort of in several sort of categories. So the first is risk assessment. So, who may be harmed by the disease, who is going to be adversely affected by this, what are our responsibilities? If we delay treatment, are people going to be hurt? If we proceed with treatment, are people going to be hurt? Mm-hmm. And the concerns with delaying treatment are people who may suffer, if you will, from a delay in treatment that may be, 3 months or more. And we want to make sure we reconcile those needs of those patients. And then the other concern is moving forward too quickly and exposing people to getting the disease. And I think one of the concerns we have is, certainly if we flatten the curve and treat the disease and then we relax some of the restrictions that have been imposed, are we going to get a second wave of disease, and could that set us back further? So these are factors that have to be weighed. And I think that, we also don't know the impact of this COVID-19 on a developing fetus. There's certainly the people that were pregnant in January of this year, early pregnancy, have yet to deliver. So we really do not know the full extent, and we won't know for a couple of years, the full extent of the impact of the virus on pregnancy. Mm-hmm. So these are the things that I think have to be balanced as a first step.
Okay. And
then, yeah.
Sorry, I'll let you continue.
No, but then we have to think about, risk mitigation. So I think we have to think about, when we think of our ability to care for patients, what can we do in the office to reduce the risk? And certainly having strict guidelines for keeping patients at least, 6 feet apart, for wearing masks, for hand washing, for screening people to see if they, have any symptoms of the disease. For using protective equipment to maintain, help prevent, again, the spread of the disease between our staff and our patients. And then I think that we want to make sure that we screen our patients as effectively as we can. And currently in the United States, we do not have wide screening available, either the RNA test or the antibody testing widely available. And it's not feasible for us to screen everybody with those tests to see if people have the disease or not. And the other problem is that the screening test to see if someone has a disease, how often do you have to do that? Because someone could screen negative and then the next day be infected. So I think those things are very difficult. So currently the mainstay of our screening boils down to temperature and history taking and exposure taking, and then self-protecting. So those are things that we really want to optimize to keep our patients safe and to screen for those who may be at risk of having the disease. Okay. I think we also have to think about, what are the risks to that individual patient when you think about going ahead with treatment versus postponing treatment. And for everybody, it may be a little bit different. So those are things that we really have to consider. But having a very strict policy in the office that everyone's familiar with, and guidelines that are written down, that are created by that individual office, that can be followed very carefully.
Mm-hmm. That sounds, yeah, I can understand that. I guess also with the field of fertility, obviously a lot of it does. I mean, a lot of it is physical examination. So, as you said, in terms of cross contamination and things like that, obviously there will be huge vigilance in terms of keeping things very, very clean, and the checks that will have to happen with all the equipment and the staff and the protective gear that you wear, etc. Um, I
Well,
guess
the protective gear is actually just masks and hand washing and social distancing are very important. So those things are critical. The other thing is, you know, changing your practice pattern to avoid too many people coming into the office at one time. And, you know, for many IVF centers, the blood work and ultrasound that need to occur often occur in the morning, and there may be, you know, ebbs and flows of the number of people there at any point in time. And clearly, you know, we cannot tolerate having too many people in the office at one time, all standing there together waiting to sign in to get their blood and ultrasound done. So spreading those over time, and certainly, you know, practices are looking at ways to reduce the number of patients in their office at any given point in time. So extending hours and structuring the visits so that we reduce the number of people that are standing there together. And those are all very important things to think about.
Because I guess a lot of your patients would come in to see you before work, wouldn't they? So obviously, you know,
Yeah.
7:30 a.m. is probably quite a popular time, for example.
Oftentimes it's 8 o'clock. People, you know, we do ultrasounds in the morning till about 8:30, and we get a large number of people come in 8:29 and a half, and like, here I am, I'm not late. So, but I think that, you know, those days are gone. And in a way, it, you know, I think that having a structured time, the intent is that it'll decrease the amount of time the patient is actually in the office, and that can benefit everybody. So I think that's good. And still maintaining telehealth and utilizing telehealth for any visits that do not require ultrasound or blood work or an exam or anything of that nature. To, again, keep people safe, keep people out of the office is really important.
Actually, I guess what COVID has shown us is that people, because we're being forced to, people are actually, I wouldn't say adapting well, but we're using the resources we have to make things as virtual as possible. And there have been surprises in terms of how well that can be working in certain areas.
Well, I think it's good. One of the things also is that having partners come in with the patient during monitoring and things of that nature, that is not ideal because we don't want extra people in the office. So we're utilizing FaceTime. So we've had patients come in and we'll do FaceTime when they're having an ultrasound, so we can engage the partner, but utilizing technology rather than having them in the office. So there's ways that we can sort of utilize technology to include everybody in the care, but in a different way.
Really,
so creative ways are popping up. It's nice.
Great. And back to your first point around not necessarily prioritizing is the wrong word, but in terms of staggering patients so that there isn't suddenly an influx of patients at the same time.
Yeah.
For people who are concerned that they might be left behind because they don't fall into a category of urgency, what would your thoughts be around that?
So, you know, we are all thinking about strategies for that. And it's kind of interesting because we initially thought there was going to be a huge onslaught of people who aggressively want to start treatment, or anxiously, I should say, want to start treatment, which, especially the people whose cycles maybe were not started because the COVID hit. But it turns out that there's a lot of people that are actually reluctant to go ahead with treatment because of the concerns of COVID. So, you know, I think that clinics are offering expanded hours and ramping up to accommodate the volume of patients. And, you know, certainly no one can't have everyone starting on the same day, but we don't envision a huge lag time to get people treated. So I think that, you know, we are all working to try and reduce, you know, a problem. And clearly there's some patients who may be better served by being treated sooner than later, and some people who could wait an extra month perhaps to start without any trauma or difficulty. So, you know, that is certainly what every clinic is struggling with, how to do that. But I think that we don't foresee a huge delay in people getting back to treatment. So I think those things will work itself out. But, you know, most clinics are expanding hours and trying to accommodate people and get people in. We're all committed to help the patients pursue treatment again. It's really hard not to. One of the other things in the United States that's a little bit different is that we have different areas of COVID intensity throughout the country. And US is a pretty big country. So we have areas such as, you know, New York, where things may be subsiding a little bit, but we have other parts of the country of the COVID pandemic is on the rise. And we have other parts of the country that really have a very low level of COVID disease. So a lot of our opening up of the clinics can be dependent on the government regulations of that area. So those are things that it may be different in one part of the country versus another.
That's so true. So am I right in thinking that California and New York are the worst hit states?
They're two of the worst hit. Yeah, Southern California is bad. Washington State, and you know, other places are big cities are ramping up. But New York is clearly the epicenter of the country. Yeah.
Well, thank you very much for that. I guess the other thing I was going to ask was that some clinics, and I believe Cornell, from having been a past patient, is the same, close for maybe a month during the summer. Mm-hmm. So, and the lab shut down for a month during the summer. Is that something that you think might change, given there's been a closure during this time, or do you think that the way that things were set out previously might stay the same? Because I know lots of European clinics, for example, do shut for a time over the summer.
Mm-hmm. I think you've got to ask, why did the clinic shut in the first place? And you have to recognize that a lot of maintenance, cleaning, all of the things that have to happen in the lab cannot happen while you have active embryos or eggs or sitting there on the counter. Anything, just even the dust from changing an air filter can destroy the media and affect the embryo quality. So in order for the labs to do any routine maintenance or routine activities to maintain the equipment and such, can only be done if there's no ongoing cycles at that present time. Mm-hmm. Okay, so, and that they need to do that periodically. So that is one of the major reasons why the lab is shut down for many centers. So I think for many of us, this 6 or 8 weeks we've been shut down because of COVID, you know, people are still working. People are still, you're not sitting at home. Yeah, so people are able to get a lot of these things done. And so I think many clinics are going to not close during the summer and to keep open. And for many clinics that were closed, typically for a period of time in the summertime, you know, if you think about, okay, they had the closure in the spring and now most clinics are probably going to be open that whole time, that gives plenty of opportunity to accommodate the backlog of patients whose treatments have been deferred because of this acute COVID. Mm-hmm. So I think that there's certainly capacity in the system, and with extra effort that the practices are putting forth to get patients in, to take care of them and treat them, I think we should be able to accommodate people.
Great. That's really reassuring to hear. Thank you so much. Yeah. So what would be your kind of takeouts for anyone watching this in terms of next steps and summarize what we've just discussed?
Sorry, well, I think, you know, my thought is that COVID is here to stay, and we need to switch our mindset to say, now we practice in a time of COVID. Just because COVID is here doesn't mean we're not going to practice anymore. We have to practice in the era of COVID. And how can we do that safely? How can we minimize risks to our patients? I think we have to recognize that it's a rapidly evolving situation, and there's so many things that we really don't know about the disease, about the impact of the disease, about testing for the disease, about what the impact is on a developing fetus. So there's many things we don't know. And so how to proceed with that in mind to safeguard our patients and our staff and minimize that risk to everybody. But at the same time, realize that everything is so rapidly evolving. I mean, the advent of what testing we can do and the advent of what testing for antibodies to see who is immune to the disease. And then hopefully in the near future, we'll have vaccine that'll be, help prevent people from acquiring the disease. So there's so many things that are rapidly changing that I think it's exciting that we say, okay, it's okay to resume treatment and to plan a very safe strategy for doing that. For many people, that may not just be dependent on the clinic, it may be dependent on the rules and regulations of the area, but then to proceed as we can, maintaining that as safe treatment as we can for our patients, but the thought that we will, we'll be able to live with this disease and conquer it eventually, and how can we do that safely in the meantime? But I think we can.
And as you say, everyone's been working so hard behind the scenes. So for the patients to know that obviously all the clinics have their best interests at heart, and obviously with your position on the ASRM, you know firsthand how much work is going into finding other ways to navigate the situation that we find ourselves in.
Yeah, I mean, I think all of us collectively have heard from our patients and feel for our patients, and it's really difficult to have your plan disrupted. And I think that we recognize that, and we're committed to helping get back on track in the most safe way that we can.
Mm-hmm. Brilliant. Thank you so much for your time today.
You're welcome. Thank you. It was wonderful to see you again.
Thank you very much.